Okay, I think we'll go ahead and get started. This is the Quality Exchange call for stroke. First of all, I want to wish everybody a happy Halloween. Good afternoon. My name is Deb Moats, and I am the Senior Director for Stroke and AFib for our 6-state Southwest affiliate. I'm joined by Allison Capitillo. She's the Director of Quality and System Improvement for Houston, and she's also our affiliate lead for stroke. We would like to welcome you to the second Stroke Quality Exchange. This is a quarterly call this is actually the second one, but it's a quarterly call to allow our hospital teams to come together and learn from each other, share, identify resources needed, and just kind of help one another out with process improvements and things that you're doing in your hospital to improve stroke care. I hope you'll invite your colleagues to join us. Everyone is welcome on the call, whether you get with the guidelines or not. We are also holding quality exchange calls. This morning we had heart failure, which was an excellent presentation. Tomorrow we have resuscitation at 8 in the morning. We have atrial fib at noon, and then coronary artery disease will be presented as an exchange call on Wednesday morning at 8. So for now, everyone's been placed on mute, but to join the conversation, just select *6. We want this to be interactive, so don't hesitate to unmute and speak up. We really want to be able to help one another and answer questions. So the topics for today's call, we're going to start with a brief overview of the Get With the Guidelines stroke release that was released on October 19. We're going to have a couple of the Houston hospitals share best practices for stroke management and group discussion and questions. We also may have a presentation from Baylor Scott White in Grapevine to talk a little bit about a process that they have implemented. And then we'll just briefly go over the Comprehensive Stroke Center measure update. We'll talk a little bit about the intensive statin. And then we're going to identify the top 3 measures that most frequently fall out below the 85% goal, and then we'll end with some of the resources and handouts. There were some handouts that were sent out this morning. If you did not receive them, then please email Larissa DeLuna at heart.org. That's LARISSA.DELUNA at heart.org. And she can send those to you. So let's go ahead and get started. As I don't know if you recall, but from our last call, what we decided to implement through the American Heart Association and Quality Systems Improvement areas, we've decided to provide you all with an update, a snapshot of where you are with your Quality Achievement Awards and the PLUS Awards and also Target Stroke. Hopefully you've all received that report. And please know that this is just a snapshot. The Get With the Guidelines PMT is a fluid tool, and so every time somebody enters in, then things change. So this is just a one-time snapshot of where you are in the first 3 quarters. And also there is a date on your email that tells you the last patient that was entered, so you kind of have an idea where this is at. And these reports can be run by you at any time using your configurable report. And if you don't know how to do that, then please contact your AHA representative, QSI representative, and they can actually help you walk through how to run those reports. So now to kick us off, Allison, I'm going to turn it over to Allison, and she's going to discuss the brief review of the stroke release and also the Houston hospitals and the intensive statin measure. Allison?
Hi, everyone. I hope you all can hear me okay. I apologize. I just got interrupted by a phone call that came through, and it kind of messed up my notes here. So let me just get back to it. So the first thing I'm going to go over today with everyone is to talk about the most recent revision to the PMT, so Get With the Guidelines Stroke. And if you all recall, there might have been an email that came out to you directly from Quintiles with an attachment that had the release notes. And you all probably also got an email from Larissa DeLuna, who would have sent it out from our quality email as well. So if you have gotten a chance to look through that, great. If not, we're going to just go like a high-level highlight right here. So first off, there were a couple of things added for sites that are enrolled in our MERIS and ARAMIS programs. These are both research programs that some of our hospitals are working on. There are new components that have been added to the PMT directly for those hospitals. So if you are signed on and you have those items enabled for those two research projects, then you should see there are a couple of new items that are probably going to have to be included in your abstraction. So just be on the lookout for that. If you are not seeing these items and you are an ARAMIS or MERIS participant, please let your director know so that they can help you get that stuff activated. The next thing that was released was the addition of a new telestroke tab, and this is for both providers of telestroke and receivers of telestroke. So if you are a hospital that pertains to, you might want to listen up to this part. So if you are interested in turning this on, this is a free feature of Get With the Guidelines. You will be able to have added into your PMT to track your telestroke metrics. This is for you. I'm just going to go quickly over kind of how to do that, but we can definitely provide you some more detailed instruction in writing if you're needing that. But if you are interested, listen up for this. This is, if you are a provider of telestroke consultation and you are looking to add this to your tool, you're going to want to enable this under your stroke site characteristics. So on your home page, you're going to look down towards the kind of the middle on the left-hand side. There's a section that says Update Stroke Site Characteristics. You would click on that and be able to see a place that indicates where you want to enable or disable telestroke consultation. So once that's done, you're going to have to log in after the update takes place, and it'll have you agree to a new terms and conditions of agreement for Get With the Guidelines. Once that's done, you should begin to see the new components added into your PMT. So you would see a brand new tab added into your tool. As a site, you will have to indicate whether you are primarily a provider or a recipient of telestroke consultation. The next thing I want to go over are a couple of issues that we've noticed that have come up since this release of updates. There have been a couple of issues with folks that have had difficulty saving their abstraction because of errors in either the arrival method, or I've seen a couple of people that have had difficulties with some PPA components as well that are not saving. So if you're having difficulty with these, please know we are working on this diligently. Quintiles is aware of the problem, and they are working on a fix for this. So we're hoping to have a resolution to that here in the next few days. If you have not seen a resolution in the next week, please let us know that you're still encountering these problems. It's difficult for us sometimes to see whether or not these are still happening since we're not the ones putting the data in. So please just let us know. I would also like to talk quickly about a couple of our presenters today. We're going to have a couple of hospitals presenting on a best practice that they've implemented to improve some of their measures, and specifically the time to treatment for TPA. Of course, we know this is important to everybody, and this is definitely at the forefront of a lot of our programs, so it's great to hear some of the things that hospitals are doing to improve their timing. So first up, I'm going to introduce Ms. Marcia Carlton. She is from Clear Lake Regional Hospital here in the Houston area. She has a background in ER nursing and education as well. So she has worked for about 20 years in the nursing field before she switched over to the coordination side, and has now been in the coordinator role for a little over a year, I believe, and has done some really great things, including helping get her hospital to its first comprehensive stroke designation. So, Marcia, if you are ready, I'm going to let you go ahead and jump in and talk about what you guys have implemented at Clear Lake.
Okay,
Marcia,
hi.
Go ahead.
Hi, Allison. Okay, so again, I'm Marcia Carlton from Clear Lake. And yes, I've been in this role for about a year, so I'm still new, still learning things. And I do have a background in ER, so I have a great reputation, great conversations with our ER people. And so they've been very generous. They've done everything we've asked them to do. So a couple of things that we started just trying to change one thing at a time. We started with changing our EMS patients that call prior to arrival and let us know they're coming. We would take them directly to CT, get the CT done first, and then they would go to a patient care room. We started that in April and had great success with that. One concern when we went through this process was we were concerned that the lab the lab draw times were going to get extended, since we were focusing more on the CT times. What we found out, surprisingly, was it made the whole process better. Our lab times got extremely low. They were wonderful. We have our lab tech actually comes to all of our code neuros, which is what we call code strokes here. They meet us when the patient arrives, and most of the time they will just do a direct stick on the patient, just do a butterfly, draw the labs, and go. Before that, we had kind of been waiting to draw the blood from an EMS line or starting a line of our own, those kind of things. But just to get lab to do a direct stick and go has really helped their times. The other thing, when we sent that out, we also started having EMS draw blood for us. We've tried this a couple times. I've been at Clear Lake for about 10 years. We've tried this a couple times, and it's not really worked too well. We decided to try it again. So we have bags in the EMS room for them to take and stock on their ambulances. And if they're able to, if they have the ability to, is to go ahead and draw the labs for us when they're en route to the hospital. So that way our lab tech just has to walk in, pick up the blood, make sure it's labeled, and go. So we started this with EMS, and we had great response. Our numbers dropped really well. So then we moved it into the walk-in patients. So we know whenever people would bring people in, they'd stop at the front desk, they'd ask a bunch of questions, they get recepted into the computer. Before you turned around twice, you were there 20 minutes and you haven't gotten anything done. So we also started this straight to CT. If the patient arrives, they get recepted into the system, and they go straight to the CT scanner. And then they'll go back to the patient care room and finish everything there. So that we actually started that full-blown about the middle of September. So we don't have a lot of numbers on that, but it has definitely helped our times. The big thing that we're working on right now, which we've been talking about for a few months, and everybody's processes are different, but here, earlier in 2017, the pharmacy part of this changed. And instead of just pulling the TPA or the Alteplase, mixing it and giving it, our pharmacist had to stop and do a thing called compound verification, which is going through multiple screens on a computer and scanning the bottles. And it takes between 5 and 7 minutes just for that process. So that was really extending our times, and we were frustrated because we're standing there looking at the medicine, but we couldn't give it yet. So we are getting ready to start trialing using Alteplase as an emergency drug, because that's what it is, and being able to have the pharmacist mix it with the ER nurse at the bedside, give the bolus, start the infusion, and then they will go back and through the EMR, and they will full document the actual time that they gave the bolus and the infusion. So we are hoping to shave off anywhere between 5 and 10 minutes of our times on each patient, because time is brain cells. So that's something that we're starting to try. Like, we actually almost did it today right before this call, but the patient refused. So hopefully that also will help. If that comes to fruition and it seems like something that everybody's going to do, I can put that out there again, kind of our process that we're using for that. We did have a patient that we just gave TPA to over the weekend in 23 minutes, even with that process, but that's not the norm. So that's kind of where we're at. And that's really all I have, unless anybody has a question about it. Allison, are you still on?
This is Susie Mitchell, stroke coordinator at Covenant Medical Center in Lubbock. I have a question for you. Have you thought about the nurses mixing the TPA?
We have, and that's always been a question. So for our comprehensive survey, when we were getting ready for that, there was a lot of questions about that. The problem with our nurses, we have a pretty large ER. We're a level 2 trauma as well. And so we have about 80 nurses. And so to be able to have competencies on everyone, we went to having the pharmacist mix it, because that's a lower number of people that you have to have competencies on and that they know exactly what they're doing. We have pharmacists in the ER 12 hours a day, so from 10 a.m. to 10 p.m., and then we have the backup pharmacists that are actually in the pharmacy will actually respond to our code neuros in the ER on the off times when we do not have a pharmacist. So that helps us. I know a lot of places don't have that, but we did that for the quality aspect of being able to have competencies on a smaller number of people than trying to get everybody doing the right thing.
So you're similar then to what we have too. The 12 hours we have the pharmacist available. Our times for TPA are just over 60 minutes, and I was trying to shave off some time by having nurses mix, but that is an issue, competency. So
right. Do y'all have to do the compound verification or any other billing issue things before it's given?
Yes.
Okay.
Yes, I'll look into that as well. Thank you.
Yeah, and because we've been arguing this, because as an ER nurse for 20 years, when we're doing a code, we're given all these drugs, and we're not scanning, we're not doing anything, we're saving this person's life, and then we're going back and full documenting the actual time that we gave it. So that's kind of the hurdle we're trying to cross right now.
Correct. Okay, thank you so much.
Sure.
Thank you, Marcia. I'm so sorry. I must have been on mute and didn't realize it. That is wonderful information and really, really good to know about the compound verification. I actually didn't even know that, so thank you for sharing.
Yeah.
If anyone comes up with questions in the meantime, we're going to go ahead and let Donald present, and I will definitely take more questions at the end, and we'll let both of these wonderful coordinators jump in and answer questions for you guys. So real quick, I'm going to kick it over to Donald Garrett, who is the stroke care at one of our other facilities here in the Houston area. And this is a facility that is actually going to be pursuing comprehensive certification, I believe, this year or next year, right, Donald? I think that's what we talked about. And Donald also has a background in ER nursing as well and has been a paramedic for a number of years. So he actually brings a really unique perspective to the stroke coordinator role. And I'm excited to have him share with you guys a little bit about how he's created a culture of stroke care in his hospital. So with that, Donald, I will go ahead and let you jump on if you want to do *6 to unmute.
Okay, excellent. Hello there. All right, hello everybody from Houston, Texas. I just want to start off with the attachments they sent for this conference call, the 12 Key Best Practice Strategies form that they sent. We have basically adopted just about all of those, except for mixing the altoplace ahead of time and having a time or clock attached to the chart. I'm sort of that person because I respond to all the code strokes in our facility. So they sort of know when I'm standing there that I'm sort of ticking the time off as we're there. So I'm sort of the substitute for that. But definitely the 12 best practices that they have are things that will definitely cut time out for the door-to-needle times for your stroke patients. So I would definitely recommend any of those. And if you have questions later on as to how we implement some of those things, again, you can let me know or you can email as well. But one of the things, there's a lot of practices and processes we can put in place, but really we have to have the people in the ED to actually follow them and do them and accept what we're wanting them to do for the stroke patients. The way I approached the ED staff in the very beginning when I sort of first came was, letting the nurses know that they are the patient's advocate for stroke while the patient's there as a stroke patient. The ED nurses are constantly being bombarded with having to meet certain metrics or different type of patients they care for, and we have to market our service to stroke patients of saying our patients are just as important as all the other ones. So sort of one of my philosophy of the ED nursing staff is, they're the ones running the code stroke, the physician's there to order the medication and sort of confirm what the nurses are seeing, for that particular patient. But when we look at the code stroke pathway, almost everything is nurse dependent. Nurse recognition of the stroke symptoms and triage, calling a code stroke immediately, getting the patient straight to CT, getting IV access, labs, quick assessment, and having someone holding the TPA medications, so they can mix it immediately when told by the physician, and having all the supplies needed to mix and administer TPA in the CT suite. While mixing and administering the TPA, the CT techs are prepping the patient for a CTA to rule out a large vessel occlusion possibly. And, of course, documenting all that happened, in the EMR and getting all the times correct for us. So when stroke coordinators go back and abstract the case, we can sort of pinpoint there's any, time we could have made up possibly. What I say to the ED nurses is that we need to find a reason why we shouldn't give TPA rather than, why we should. So trying to turn around their thinking a little bit. It's just a different way of thinking about giving the TPA. I also advocate that a stroke coordinator respond to all the code strokes in the ED when available. Not to assume patient care or direct what the nurses are doing, but rather be a spectator that may ask why they are not doing something along the stroke pathway, and support them, and let them know they're doing a great job, if they are following that, of course. If the ED team veers off the normal course, we can redirect if needed and offer that support. The last thing is every ED team needs is feedback. Within 48 hours after a patient's given TPA or goes through a thrombectomy, I send a breakdown to the ED, lab staff, CT techs, neurologists, stroke leaders of how these cases went along, with the time metrics. The team has to know what the goals are and how they're doing as a team, setting realistic goals and giving them time to improve. Some of the time metrics that we've had, basically over the past 2 years or so, we've gone from door-to-heel times of 60 minutes or less, around 40% of the time, to this year so far we're at 60 minutes or less, around 96.2% of the time. And we've cut the 45 minutes down to 82.7% of the time. So our goal actually is 30 minutes or less in the ED. If we hit 45, that's sort of okay too. So between 30 and 45 are our door-to-heel times we're trying to meet. And a lot of times they even beat that. So just changing that philosophy and the ED nurses thinking of it's just another patient when really, they're the ones who are impacting each of those patients' outcomes, when they get those type patients.
Thank you, Donald. That's really, really great. Really actually love y'all's philosophy of turning the thought process around about giving TPA and thinking of it more of looking for reasons not to give the TPA rather than trying to find a reason to give it. It really does change the way you're thinking about it and kind of opens up the realm of possibilities of the number of patients that would be able to get TPA. Does anyone have questions for Donald or Marcia about their processes or anything that they've implemented in their hospital?
I would ask Donald.
Go ahead.
I was going to ask Donald, this is Susie again, if the nurses mix the TPA at his facility.
We also have the pharmacists during the 12 hours during the day. If they're available, they usually mix it. But then again, if they're in a meeting that particular morning, guess what? The nurses have to do it. So all the ED nurses are competency, actually hands-on competency, mixing and administering TPA, rapid response, and all the ICU nurses as well.
Thank you.
Great questions. Anyone else have any questions? Okay. I will jump in, I guess, real quick with one more thing. I was going to add to our PMT updates list that I forgot to mention earlier. If anyone is having difficulty with any of the elements that have been added to the advanced stroke care tab, if you'll recall, this was to replace what used to be called the MER tab for hospitals that were collecting data on thrombectomy patients. All of those elements and some of the neurosurgery elements have been rolled into what's now called the Advanced Stroke Care tab. If you are a site prescribing to the CSTK layer for Get With the Guidelines, you will automatically given the Advanced Stroke Care tab. You won't have to do anything to activate that. So some of your data elements that used to be in the hospitalization tab have been moved to that new Advanced Stroke Care tab. And really this was just to streamline the data collection process a little bit more, to kind of put all of those elements that did not pertain to primary stroke centers into one place, and then to put all the elements that would pertain to a higher level of stroke care in one area of the PMT. If you are a site that is collecting data on large vessel occlusion patients because you're planning to pursue comprehensive level certification, or you're planning to go for the new thrombectomy capable site certification that's going to be coming next year, please let us know if you need help to get these elements added to your PMT. We can certainly help you get these activated, and I believe that should not be at cost to you. The only thing that is has a cost associated with it is the addition of the CSTK layer, which would automatically pull your data elements for Joint Commission submission for CSC hospitals. So that's all I had to provide, on the PMT update. I am going to kick it back now to Deb to talk a little bit more about the CSC performance measures. So Deb, if you want to jump in.
Thanks, Allison. So I think before we talk about the CSC measures, we have Jamie Getzmeyer on the line. She's from Baylor Scott White in Grapevine. I spoke just briefly on our last call about a new smartphone technology that they're using to improve stroke and STEMI care. And so I'm going to ask Jamie to share a little bit about their processes, how it's working out for them, and what kind of improvements they've seen as a result. So Jamie, star six to unmute your line if you're available.
Okay, thank you. Yes, I'm here. We've been using Pulsara since last November, and I think the last time I talked a little bit about it, and we're using it for both our STEMI and stroke program, but we're really excited we are working on comprehensive stroke, and we'll be able to use another part of the technology, and that is in activating our IR team, which will be really neat because the pagers definitely are kind of old school, but what we've noticed is that two-way communication that Pulsara allows has been really valuable between our staff. We're noticing in the code stroke when EMS activated in the field, we all know right away who's acknowledged it and who's going to be coming down to the ED. We have a neurohospitalist who is sometimes up on the units, and he's able to get the page, or not the page, but get the notification, and then we can tell that he's on his way coming to the ED, so having that neurologist almost there as soon as EMS pulls in has been really invaluable. We have the people that are in on it with us right now is we have pharmacy pulled in, we've got our neurohospitalist, we have our ED physician, our nursing staff, radiology, and I think I said pharmacy as well. And so our whole team is all on that, and we can communicate. We are in the process of rolling out to the inpatient side as well. And there again, the communication is really nice because if we want to know which CT we're going to be taking the patient to, we can text that and know where we're going. The physician knows what room they're going to and can find out very quickly where the staff is. In the past, sometimes it would be the physician was up on a different floor and didn't even know where the patient was, if they were in CT or on their way through the hallway. But it's just a really nice way to keep in touch. The neat things for stroke coordinators is all of the information that's in the app is exported in a spreadsheet, so you're able to track all of your pulse activations, your activations, all your door-to-needle times, everything like that. But all the steps in between are also captured, and so you can break down processes that may be taking too long and then know where to kind of shave time off. Our pharmacy is probably one of the most active on it, and as soon as we know what the patient's weight is, we can enter that, and then the pharmacy can be pre-calculating the mix on TPA, and then as soon as we know that the physician has assessed the patient and says, yes, go ahead and mix it, we text the pharmacy and say, per Dr. So-and-so, mix TPA, bring to room such and such. And so all those pieces that were phone calls, like stepping out of the patient's room, having to tell the unit secretary to contact the pharmacy or call the doctor, things like that, those have all been broken out of the process, and we can see it on Pulsara and do it, from the app. We have actually decreased our door-to-needle time from an average of about 60 minutes last year to 44 minutes this year. And so I think it's been a great way for us to reduce some of the door-to-needle times just by zeroing in on processes that were a little bit broken. Does anybody have any questions on that? I'm trying to think of some other things that we've done. It also provides feedback to EMS right away, if the case was stopped for whatever reason, or if we gave TPA, they get that door-to-needle time. So pretty cool process. On the flip side, there's always some cons to things, and some of the things that we're finding out what are difficult is people don't like change. So getting everyone on board and changing the process that they have has been challenging. We don't really encourage our ED nurses and our staff to pull out their phones and use them in front of people. So we had to be creative, and we purchased a couple iPads, and we used those in the units rather than ask people to use their cell phone. One, we don't want to have to pay for their cell phone. Everything is HIPAA protected, but the iPads have been kind of a nice answer to that. The other piece that's kind of a con is that, no, the data does not merge into the medical record yet. We're hoping that it does do some merging at some point so that we're not having double charting. But all in all, I think the process itself has helped us tremendously.
So, Jamie, are you able to print from the Pulsara app so that you can just add that to the chart, or you need to double chart?
Yes, no, actually we are. When you go into the website and you start exporting your data, because it exports all into spreadsheets, you can actually, if there's an EKG there or a picture of something or any type of documentation in there that you want to capture, you can export it, or sometimes I'll even do a little snippet and do a screenshot, and then I can actually label that with the patient's information and get it scanned into the chart. A lot of our inpatient RRTs, some of our medical record that we have access to, doesn't always allow you to chart the specifics that we need on a code stroke on the inpatient side. And so the information is actually on the Pulsara website, and I can go in and print that, put a patient sticker on it, and then scan it in. So it is able to be recaptured. It's just a little extra step, but I think at some point it may be where it merges.
Great, thank you. Anybody else have any questions for Jamie? Star 6 if you have a question.
Hey, Jamie, this is Allison.
I have a question. Sorry. This is Jessica at Lutheran in Colorado. Did I also hear that the Pulsara allows for communication about patient information when EMS is en route, like name, age, that kind of thing as well?
Yes, actually, Pulsara is completely HIPAA protected. It goes through the cloud, so there's no breach of patient confidential information. And what we're working on is getting EMS to, if they do a picture of the monitor and it shows the vital signs and things like that, some of them have even laid the driver's license up there. And so we're able to pre-register these before they even get here. But yes, you have access to that information. They can do up to 3 images on the app itself at this point.
Great, thank you. Do I star 6 to back mute?
Hey, yes, Jamie, this is Allison. Can you guys hear me?
Yep.
Okay, perfect. So I just had a quick question about the implementation. Were you guys the first to adopt the Pulsara platform, or was EMS in your area?
I was actually the first one to adopt it in our area. The fee actually comes from the hospital, and then it's free to the EMS agencies that you pull on board. So it was actually something that I initiated and instigated from our end.
Okay. Did you feel like it was pretty easy to get the EMS agencies on board and collaborate with you guys?
Absolutely. Yeah, they actually took to it a little bit better than some of our hospital staff did. I don't know if they're a younger crowd and more techie or what it was, but EMS bought into it very easy.
Awesome. Thank you.
Great information. Thank you, Jamie.
You're welcome.
Okay, so now we're going to switch gears a little bit and talk about comprehensive stroke measures. Starting January 1st of 2018, there's a few changes that are going to be made to the performance measure requirements for comprehensive stroke for the Joint Commission. So now there will be 10 mandatory comprehensive stroke measures as of January 1, 2018, for meeting the performance measure requirements. So the changes to the CSTK-2 measure, modified Rankin score at 90 days. So originally, this was intended as an outcome measure, and it was modified prior to its 2015 implementation to focus on the process of obtaining the score at 90 days. So the modified Rankin has become the most widely used clinical outcome measure for the clinical stroke clinical trials. So comprehensive stroke centers now have processes in place to collect 90-day Rankin scale data and aggregate the performance is nearly at 90%. So that is no longer going to be followed. Also effective, also effective, hold on. So with the effective January 1 stroke 10 modified Rankin score at 90 days, the favorable outcome will be added to the CSTK measure, and this outcome measure captures the percentage of stroke, ischemic stroke patients that are treated with the reperfusion therapy, whether it be IV or IA or mechanical reperfusion. And it's looking for the good outcomes for the modified Rankin of 0, 1, or 2 at 90 days. So stroke 10 will replace the CSTK-2 measure. And then also effective on the 1st, the CSTK measure will include the new measure, number 11, which is timeliness of reperfusion. So it'll be arrival time to the TK2B or higher, and the stroke, or STK-12, is timeliness of reperfusion. So skin puncture to the TK2B or higher. So these are robust measures of mechanical reperfusion effectiveness, and like I said, they will be effective January 1. If you need more details about that, it is on the specification manual for the Joint Commission National Quality Measures on their website. So any questions about that I can answer?
Yes, if you are in, this is Susie again from Lubbock, if you're an advanced primary stroke center and we do thrombectomy and we don't have 24 IR coverage, so we're advanced primary, do we still collect that data?
Only if you're going to be reporting it as a comprehensive stroke.
Okay, thank you.
So if you do want to add...
This is Michelle Rogers. I'm the stroke coordinator at Methodist Dallas Medical Center. I was just wondering if you're going to start putting in some of the DNV measures into Get With The Guidelines instead of all just Joint Commission.
We have been working with the DNV and also with Quintiles, trying to get those measures married up. So I'm not sure at what point that's going to happen, but we are looking into it and working on it. And most likely the DNV measures will probably match up because they're all based on the clinical practice guidelines. So eventually we'll probably match up with the recommendations for the clinical practice guidelines. But that's what I can answer for you right now.
Thank you.
Any other questions? Okay. I think I'm going to turn it back to Allison just to talk very briefly about the intensive statin measure. So, Allison?
Well, hi, everybody. So I'm going to tell you all some exciting news, exciting and probably some work ahead of it for everybody, but we are going to be making some changes to the achievement measures for 2018, and the effect will be fully in effect by 2019. So 2018 will be a transition year, and I'll explain a little bit in a minute what that means. So for the first time in quite a number of years, we are going to be adding a new measure, or actually replacing one of the current achievement measures. So these are the measures that get you the gold and silver award for quality for your stroke program. So if that's something that is important to you, you definitely want to come up to this. In 2018, we are going to be changing the current statin measure to what is currently called the intensive statin measure under the quality measure section. So right now, intensive statin is not a required measure. It's one of that group of 8 that you need to get 5 out of the 8 in order to get your plus. We are going to be moving that up to the achievement quality measures, which means you need to get all of the measures at 85% or higher in order to maintain your status as a silver or gold facility. So what that means, so in 2018, it'll be a transition year. So as a hospital, you will have the option to choose if you are going to abide by the old measure, the old statin measure, or if you're going to be adhering to the new intensive statin measure guideline. So the reason we're doing this, the intensive statin measure falls more in line with what the recommendations are from ACC out of the 2013 guidelines update. So that is kind of where we're headed, and we are trying to push this into the achievement measure section so that hospitals will begin to work on getting that more ingrained into their practice. So we will, of course, you'll have the year of 2018 to kind of start making that transition and getting your team on board and getting everybody caught up to speed. And I will also note that the coding instructions for this measure will be updated to reflect the guidelines. And, of course, like all of our measures, you will always have exclusion criteria. So, absolutely we're not saying that every single person is going to have to go home on a statin. There's definitely going to be exclusion criteria, and there will be patients that do not meet that, that will not be applicable to. So just, bear in mind that will be there for you. We should be getting some more information about what the exclusion criteria will be, probably closer to the end of the year, maybe around December. So be on the lookout for webinars and announcements coming from AHA to let you know when these things are coming. So more to come on that measure, and I will answer questions as I can. I don't have much more information than that right now, but I am happy to try to answer your questions if you have any. Okay. If there aren't any questions, I will go back to Deb.
Thanks, Allison. So we're going to switch gears again now and just kind of go over what I did was review all of the reports that were sent out to everybody, and we looked for the top 3 measures that are most frequently fallouts for the 85% of the Achievement Award. So just wanted to share what the top 3 are, and also if anybody in the group if you've run into any of these issues, if you have, how did you deal with it? Any PI measures that you put in place to address these measures would be really helpful if you would like to share those with the group. So the first one is probably not a surprise. It is arrive by 2, treat by 3, and of course that goes hand in hand with the door to needle time. Now we've already had 3 different little presentations and sharing processes from some of the hospitals that have done a great job of improving these. So I don't know if there's anybody else that has anything to share, but we are happy to listen to those. I did include in the handouts, and again, if you need them, Larissa DeLuna, larissa.deluna@heart.org, and she will send you the handouts. But these are also all on the internet. So as Donald had talked to before, we have the stroke best practice, the best practices, and there's the 12 strategies. Along with that, if you go to the resources, the SWA Quality at heart.org, there's a really cute video that's about 4 to 5 minutes that kind of go over all of these strategies, and it might be fun just to show those to your ER and to some of your maybe stroke committee members, just to kind of reinforce what the strategies are and how to implement those. So again, that's on the website for SWA Quality at heart.org. And the banners will come across, and if you just click on the banner, then it will take you to the site. So the second measure that I saw that seemed to have the most fallout was smoking cessation. And I think a lot of the fallouts with the smoking cessation are related to we are seeing less and less people that are smoking. So the one rule that we have for the quality achievement measures is that there has to be at least one patient in each of the measures in order to qualify. So if there's no patients, then you would not be able to qualify for the achievement award. So it's really important to be very diligent in asking the patients about smoking, whether it was current, recent, within the last 12 months, so that those can be addressed and be included. And then the third one is the AFib, so the anticoagulation if the patient has history or current AFib or A-flutter. So those seem to be the highest three that are fallout. Also, probably the lowest volume of patients are in these measures, so that makes it even a little more difficult to achieve those measures. Does anybody have anything that they can share with us on any of those? Arrive by 2, treat by 3, door to needle, smoking cessation, or AFib that you would like to share for your process improvement? Star 6 if you have something to share. So I know in previous positions that I've had, the smoking cessation one, we made sure and added that to all of our educational materials with some links as far as where to go to find more information. So that kind of helped us to achieve that measure. We also had the respiratory therapists were notified when a patient was a smoker, current or within the last 12 months, so that RT could visit with the patient and do some of that education. So that was one way to handle that one. The AFib measure, I know another thing that we've done in the past was included all of the documented reasons for possibly not starting the patient on an anticoagulation, so it was just a checkbox. So if the patient had AFib or a flutter, then it was a checkbox. If they weren't on anticoagulant, why not? And that really did seem to help improve performance measures in my previous position. So anybody else have anything that they've tried or done to help with that? Okay. I know there's like 50 or 60 people on here, so a lot of information can be shared on this quality exchange. So next,
Deb, I'll jump in. I'll jump in and share. I know one thing at my previous facility we did was, I know a lot of people are against these, but in things like smoking cessation, where that's actually a metric that applies to so many different disease states across the hospital, and it's really important that it's captured on admission, is to make that a hard stop. And I know that's not something that everyone loves to hear, but on admission, it's definitely something that can be incorporated into the admission note for the nurse to address. And I believe probably a lot of places are already doing that, so I don't think that's unique by any means, but it's definitely something to consider if it's something that you are having a difficult time capturing. That's all I got.
Thank you. Oh, go ahead. No? Anybody else have anything to share? So if not, then we're going to move on to some resources that are available for you. So first of all, the two handouts that were given to you or sent to you the one with the target stroke best practices. And then there also was a time tracker that may be helpful for you to use while you're working on your process improvement to kind of help you to identify where there may be issues as far as timing goes and how to improve that process. Another thing just to mention is I know that a lot of times, or several patients or places have missed that show all for the contraindications. So for the TPA inclusion-exclusion criteria, some of the hospitals have selected yes, there was a reason documented, but then you have to select show all down below that in order to open up the inclusion-exclusion criteria so that you can mark what the exclusion reason was. That has been missed by some hospitals. So if you are falling out in the arrive by 2, treat by 3, you may want to take a look back at those patients and see if that's the case. You can run that report, just the arrive by 2, treat by 3 in the Get With the Guidelines configurable measures, and then if you hit instead of bar chart, select patient list, then that will provide the patient name so that you can easily just click on the patient number, which will take you directly into the record, so you can take a look and make sure that those reasons were documented. The other thing is an NIH stroke scale of 0 is a standalone reason for not giving TPA. So if there's an NIH stroke scale of 0 documented, then you're good as well. So those are a couple of handouts that were provided. Another thing, when I was looking into, I saw that some people are asking about cryptogenic stroke. So there is a website, actually, if you go again to the SWAquality@heart.org website, there's a place, it's down on the lower corner. It says anyone can have a stroke, everyone should be ready, and then it's got ischemic, hemorrhagic, and cryptogenic links under there. If you go to that cryptogenic link, there is a whole bunch of information about, there's toolkits, there's resources for healthcare professionals, there's patient education resources. There's a lot of information on cryptogenic stroke because that is being looked at more and more to try to identify what type or what could be possible causes of those that we have not been able to identify with the routine test. So if you're interested in learning more about that, then please go to that website. I think that you'll find some very valuable information. Another thing that was provided was the stroke resources. So stroke resources has just a bunch of links in it. There's a stroke treatment video that's just a short one that may be helpful for you. There's a new fast music video that goes with the music YMCA. And that's available per that link to YouTube so that you can take a look at that one as well. There's some stroke simulation events. So if you click on that link, it will take you to a bunch of information. And then the acute ischemic stroke treatment kits for the hospitals has all kinds of links to information that might be helpful for you. There's also a severity-based stroke triage algorithm. So if you click on that link, it will take you to there. Another thing is we're always looking for stroke heroes. So any hero stories. So there's a link to a Stroke Hero online submission form. If there's any particular patients that you would like to provide this link to, that they can tell their story. And then there's a campaign toolkit. Actually, it was for World Stroke Day, which happened to be last Sunday. But there's a lot of campaign information and educational information for you to share. Even though it's past World Stroke Day, there's still strokes occurring every day, as we know. So there is some helpful information there. And then there's also the Fast Act Alert. So members of Congress, you can send information or letters to your representative that are provided to help to help with the legislation that's being passed. So those are all great stroke resources for you. Feel free to take a look at those. There also is the stroke fact list. So the Get With the Guidelines stroke fact list, or sheet, that was developed in February of 2017. This sheet actually provides an overview of all the achievement awards, the current quality award, the description, and then reporting measures. And when you take a look at that, I believe it's like 6 pages long, and there's all kinds of reports that you can run. So if you're looking for process improvement, or you think that there may be something that you're seeing but you're not really sure, you can really take a look at any one of those fields and try to drill down to see. So that just kind of gives you an overview of all of the information, or most of the information that you can glean from your PMT. Let's see. So additional resources, again, the Southwest Affiliate Quality at heart.org. There's a banner there that has the AHA recognized hospitals in the U.S. News and World Report, the 2018 guidebook. So those are out. Those are available. Many of you have probably already received a copy from your director or your QSI director. But if not, then contact them and they can get you a copy, a hard copy. But you can go online and actually you can search by stroke, or by by state, to see what hospitals have achieved the silver and gold plus in the target stroke measures. So that is available for you online as well. There, on that website, there's also a link to the Acute Stroke Ready recommendations. That was a recording that happened about a month ago. So if you want to go back and take a listen to that webinar, then you can certainly listen to that recording by accessing it on that site. On January 8th of 2018, there's a stroke research. We have actually a series of webinars that we are presenting through the Southwest Affiliate Stroke Committee, and so one of those will be held. The next one will be held January 8th, and that will be talking about Lone Star Stroke Consortium with Dr. Mark Goldberg and Dr. Stephen Warwick. So there is a link to register for that webinar as well if you're interested in that. I already talked about the 12 key strategies for success video, and it's really cool. So take a look at that one if you have a chance. And last, you can expect an invitation for the Southwest Affiliate reception that will take place at the International Stroke Conference in January. So the reception will be held on Tuesday, January 23rd from 5:30 to 7:30. You should be receiving an invite for that in the next week or so. So please respond to that. It should be really fun. We have some fun things scheduled, and I think you'll enjoy meeting some of your colleagues at the reception. So just remember, we really want to hear from you. So let us know what you're struggling with, what resources you need, and anything like that, because that's what we're here for, is sharing and helping one another to provide the best stroke care that we can. So before I close, is there any last questions to be answered? If you have a question, *6, and we'll be happy to try to answer your question. Okay, there's no further questions. Thank you so much for joining us today. Our next quality exchange for the stroke will be held on January 30th at noon. That's Central Time, 11 o'clock Mountain Time. And this brings us to the end of our quarterly data exchange. If you didn't pre-register, then please email swaquality@heart.org or larissa.deluna@heart.org. And let us know that you attended, and then you will receive the resource mailing packet and a short survey so that we can hear about what you want to hear next. And just in closing, a huge thank you to our presenters, Allison, Marcia, Donald, and Jamie, for sharing your best practices. We really appreciate your time and hope that this has been helpful for all of you. So have a great day.